I'm Michelle Mello. I'm a professor of law here at Stanford Law School, and I'm also a professor of health research and policy at Stanford University School of Medicine. I'm a lawyer by training, and I have a PhD in health policy. And the work that I do brings those two kinds of training together because I use methods from the social sciences, like economics, to study empirically how the law affects healthcare delivery, affects public health outcomes, and people's health behaviors. One area that I've worked in quite a bit and continue to work in is understanding how doctors and hospitals respond when a medical error happens. Historically, particularly in the United States, there's been a lot of shame around that event. Doctors feel like they need to be perfect, and when they accidentally hurt a patient, their first instinct is to say nothing and hope that the patient just goes away, which of course they don't. They need money because they have ongoing medical and economic needs. So we have been working with a group of hospitals to change that approach. We help the hospitals implement programs that support doctors in admitting when they make mistakes and offering apologies. And then the hospitals and their insurance companies offer money to the patient without requiring the patient to file a lawsuit. And the hope is that if everybody is honest and makes amends, these issues can be resolved quickly and maintaining good relationships between the patient and the doctor. So my role in these projects is usually to help the hospital set these programs up and then help them understand if they're working by doing research on the outcomes. So in a project that a colleague here at Stanford and I did on malpractice frequent flyers, people who get sued a lot in the American malpractice system, we were interested in knowing what happens to them after they have racked up 3 or 4 or 5 paid malpractice claims. Do they change anything about the way they practice medicine? And we found they didn't do things like move to another state for a fresh start. That's actually kind of hard to do here in the US because we have a database that tracks these guys as they move. But one interesting finding we did see is that they are more likely to move from a bigger or hospital-based practice into a smaller or solo practice or practice alone. And one reason why they might do that is that they're getting pressure at the hospital or other practice where they were to improve or to leave because they're causing problems, or they might be having trouble getting insurance in the same way that they were before. And we were a little concerned by that finding because it means that doctors who probably need some help from somebody in improving the way they're practicing are instead going out on their own, where there are very few people looking over their shoulder, and most patients really would not have any way of knowing if a physician in solo practice has a bad record of malpractice. Well, one of the things that can be really hard about malpractice cases is it's often really unclear what happened. You know, the patient went into the hospital pretty healthy, they came out really sick, and then in between, we don't know what was happening. So it's kind of ironic that this new technology is called a black box because that's what the current system is. It's a black box. We don't know what goes on in there. But these technologies have the potential to really give a lot more information about what happens during surgery. And that's a good thing. And it's a good thing for both the patient who might be seeking to prove that something went wrong, but also for the team, because teams are often accused of malpractice when in fact what has happened is that the patient has had a known complication of a risky surgery and there really wasn't an error made. So there's a lot of upside to recording these kinds of data and using them in malpractice. The potential risks are that the patient might not realize how much is being recorded, so we have to do a good job of getting consent for that. And then, as in all areas of healthcare, massive amounts of data are being collected on patients and then often resold to researchers and to private companies who use them for a variety of things. I don't know that that's going on with black box data, but it certainly wouldn't be unprecedented. And the challenge there is trying to figure out how much patients should be able to control with regard to their data. In the US, historically, our position has been, well, if you take all the identifying information about the person out, all their name and their social security number and pictures of their face and things like that, then they don't really have any right to control what happens to it. But increasingly, we're now understanding that even when you strip out all that identifying information, there are smart programmers out there who can re-identify by putting one data set with another and triangulating it. So those historic protections no longer apply, and so we're really having to rethink the whole paradigm of when patients get to give permission for these data to be sold and under what circumstances. So a lot of my work has looked at why prescription drug costs have gotten as high as they have in the United States. About 1 in 5 Americans now says that they have skipped taking medicines or not filled a prescription in the last year because of concerns about cost. So it's really gotten to a critical level. And when you ask Americans what is the #1 priority for our Congress to tackle next year, it's prescription drug costs. So it's a big issue. And the question is, how have we gotten here? And looking at the system that we have, like other areas of American healthcare, but even more so, we have a system that gives private companies all kinds of incentives to produce innovations, to make new technologies, new medicines, new life-saving interventions in healthcare. And we give those incentives in the form of intellectual property rights. You make something, you get to keep the rights to it and sell it at whatever price you want. And then by essentially requiring our big public health insurance programs to buy those drugs, we make it very hard for them to exclude any drugs. And Americans get very angry when we do exclude those drugs. And it's a different situation in other countries where the national health system buys all the drugs. They negotiate with the drug companies. They say, look, we've looked at this drug. It seems kind of good. Here's what we'd be willing to pay for it. And if the drug company doesn't agree to that price, it's not bought and people don't get the drug. We're a really, really long way from that. We're still in a free market system with respect to how we get our insurance and also with respect to how those insurance companies buy the drugs for the people who they cover. So it's a system that has it's a big engine for innovation, but there's no brakes on the cost. And so it's an out of control vehicle. So typically the agency that approves a drug as being safe and effective enough to be marketed is also responsible for approving the packaging that comes with the drug and advertising that goes around the drug if you're a country like America that allows advertising. So I'm not sure how it's done in Korea, but here in the United States, once you get that drug approved, you have to submit the label and the package insert to our Food and Drug Administration, and they have to approve it. And that's really the only bulwark that we have against people, doing things with the labeling. But our law says that if you mislabel a drug, it's called misbranding, it can be a civil offense that carries big penalties, but it's also can be a criminal offense. So our Department of Justice can charge the leaders of the company with a crime. And that, I guess you could say, has proved to be a considerable deterrent because it's not really a problem that has come up here. There are lots of problems with drug companies' behavior and trying to evade the law, but this is actually one that's pretty hard to evade because the label's right there and it's online. What has been FDA approved is online for everybody to see, and the penalties are pretty stiff. Yeah, I mean, restricting the company's ability to sell its drug can be a big economic consequence, but there are probably a lot of companies who'd be willing to gamble on not getting caught if that's the only penalty. We know from other areas of the law, like criminal law, that when people make these calculations about offending, they're looking at how severe the sanction might be, what punishment might they get, but also what is the certainty with which they're going to be punished. And that's why when we get in our cars, we speed all the time, right? Because the sanction is not, it's moderately big here in the US, but the probability of being caught is really low. And so if you're a drug company, you think, well, I've got, in this case, maybe a fair likelihood of getting caught, but the penalty isn't very high. What we want, if we really want to deter behavior, is high probability of getting caught and high penalty.